We are talking about QRS morphology in cardiac resynchronization therapy. Let me introduce myself. My name is Bela Merkeley from Budapest. I am an electrophysiologist. My guests are Valentina Kutyifa from Rochester, New York, and Professor Michael Gold from Charleston, South Carolina. So let me ask the first question. What is the role of cardiac resynchronization therapy in patients with congestive heart failure?
Well, certainly I think it's a very strong role in those with systolic heart failure with a low ejection fraction, and in selected patients, randomized trials have shown that patients feel better with this therapy, they can walk further, they have fewer hospitalizations, and even mortality is reduced. So the full spectrum of both quality endpoints as well as survival benefit can be shown with CRT.
Yeah, and the first clinical trials evaluating CRT effects were focusing on patients with more advanced heart failure, but the newer studies now also extend indication to patients who have mild heart failure symptoms, and they can be considered for CRT and significantly improve their clinical outcomes.
What is the role of the ECG, the QRS read and QRS morphology, in selection of the patient for CRT?
So this is an excellent question, and QRS duration has really been the cornerstone for CRT indication since the very beginning. However, newer data now also suggest that QRS morphology, left bundle branch block or non-left bundle branch block, may also play a role. And I think for left bundle branch block, the findings are really strong. For non-LBBB, I think they may be more controversial.
Michael?
Yeah, I would agree that both the morphology and the duration are important. So left bundle branch block responds better than non-left bundle branch block, and wider QRS responds better than less wide QRS. And I think we still have more to learn about the interaction between those two factors.
Are there other factors which can influence the effect of cardiac resynchronization therapy than ECG, QRS read, or morphology?
Yeah, certainly we know that women tend to respond better than men. We know that non-ischemic cardiomyopathy respond better than ischemic cardiomyopathy. We know that atrial fibrillation can negatively impact the response to cardiac resynchronization therapy. We know that extensive scar of the left ventricle is a negative factor as well. So we have to put together the whole gamut of influences, not just looking at the ECG when we make that individual determination of whether this is a good candidate or not a good candidate for this treatment.
Yeah, although when we come back to the ECG parameters, newer research suggests that in non-LBBB patients, a prolonged PR interval may actually identify those who benefit more.
Right, so I would agree that we need to continue to expand. PR interval may be important in certain groups of patients, and again, as well as other clinical factors in those patients, which will make us determine what's best for them.
So let me shortly summarize to all of you. Cardiac resynchronization therapy is an extremely effective therapy for congestive heart failure, mostly with LBB and QRS with over 150 milliseconds. But there are some other factors which can influence the potentially positive effect of cardiac resynchronization therapy, like male, female, underlying heart disease, even the PR interval.
And can I also mention, though, that it's not just the selection of patients, but it's also the performance of the procedure and the follow-up of the patient. So where we place the left ventricular leads, how we program the device, how we follow up those patients to optimize them, also will contribute to getting the best results from cardiac resynchronization therapy. So we can't just look at them ahead of time, put in a device and forget about them. That won't give us our best results.
Fully agree. Implantation and follow-up, these are very important factors in treating patients with cardiac resynchronization therapy. Thank you very much for your attention.